Welcome to Derm Drop. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community. Episode 18 includes 4 segments, starting with topical steroids unknown GI risk, the extracutaneous adverse effect you're not screening for, followed by a don't miss DX, mycosis fungoides palmaris et plantaris. Then, livers might love methotrexate. Could long-term methotrexate be hepatoprotective? And finally, headphones that treat rosacea. Transcutaneous auricular vagus nerve stimulation is on the horizon. Fun stuff as always, so let's get started. Should you prescribe an antacid with that tub of triamcinolone? Dermatology clinicians know that systemic corticosteroids can have adverse upper GI effects, but we assume that absorption from topical exposure is insufficient to pose that same risk. But a retrospective case control study of over 200,000 atopic dermatitis patients in Taiwan, published in the October 2025 issue of Mayo Clinic Proceedings, evaluated the association between long-term topical corticosteroid use and the risk of gastric and duodenal ulcers to see if our assumptions are true. What did they find? They found that patients who were exposed to topical corticosteroid in the last 3 to 12 months had a significantly higher risk of peptic ulcers, with a pooled adjusted odds ratio of about 1.7. Subgroup analyses produced some useful additional risk stratifications. Higher risk subgroups included males, patients over 65 years old, and those with higher cumulative topical corticosteroid exposure. The subgroup with the highest risk were those who were on topical corticosteroid combined with systemic corticosteroids, NSAIDs, and/or aspirin. Patients who used all 4 medications concurrently had an odds ratio of over 8, and that scenario is entirely plausible. Consider the Medicare guy who is on a daily baby aspirin for cardioprotection, regularly takes ibuprofen for knee osteoarthritis, applies triamcinolone as needed for lifelong eczema, and flares from the Dial body wash he and his wife used while visiting their grandkids in pollen-ridden Georgia over spring break, so he goes to urgent care to get a Kenalog shot. He's doomed. Odds are 8 times higher that the next stop is Walgreens for bottles of Tums and Nexium. So yeah, it looks like even topical steroids have GI risks, and if you needed another reason to transition toward non-steroidal topicals for your chronic inflammatory dermatoses patients, increased risk of peptic ulcers is a pretty good one. But it's not the only reason, as topical steroids can have a variety of other systemic adverse effects beyond the cutaneous atrophy and telangiectasia we keep on our daily radar, such as growth impairment in children and osteoporosis in adults. Of course, there's still a place for good old topical steroids, as patients with acute conditions like allergic contact dermatitis need something they can pick up on the way home, and they're not likely to use it long term. But for your atopic and psoriatic patients, submit the prior authorization. You'll be providing safer care and possibly saving yourself from needing an antacid too from all the worrying you'd otherwise do. Next, a dermatology diagnosis you don't want to miss: mycosis fungoides palmaris et plantaris. Because mycosis fungoides is an indolent form of cutaneous T-cell lymphoma, or CTCL, we may not think of it as potentially highly morbid. But a case reported September 10, 2025 in JAMA Dermatology by dermatologists from the Netherlands resulted in a partial finger amputation. The 70-year-old man presented to a tertiary dermatology clinic following a 6-year history of pruritic dermatosis localized to the palms and soles, which was diagnosed as psoriasis and treated with topical corticosteroids, PUVA, oral retinoids, and cyclosporine until it progressed to the tumor stage and left the poor guy without a full hand. So if your stubborn case of hand eczema keeps worsening no matter what topical, biologic, or small molecule you throw at it, make sure it's not mycosis fungoides palmaris et plantaris. Mycosis fungoides is a mimicker with erythematous hyperkeratotic plaques that are famously mistaken for psoriasis, atopic dermatitis, or lichen simplex chronicus, commonly resulting in delayed diagnosis. And when it's limited to the palms and soles, the risk of diagnostic delay increases further, as palmoplantar keratoderma and contact dermatitis, which commonly occurs in those areas, join the differential. Plus, MFPP is a rare variant, like less than 1%, of an already relatively rare malignancy. And because we expect MF to present in a bathing suit distribution, it's not on the radar of community clinicians when we're looking at the extremities. Further complicating the diagnosis is MFPP's variable presentation, as the morphology can be dyshydrotic, pustular, verrucous, ulcerated, and/or nodular. So the delay goes from a median of 3 years for MF to 5 years for MFPP. In one case series, a diagnosis was delayed 10 years. There may be some biopsy inertia too, as biopsies are more difficult to perform on acral skin due to increased discomfort and thicker stratum corneum. Biopsies pose challenges to pathologists too, as the hallmark epidermal tropic infiltrate of MF may be less dense and mistaken for spongiosis. So if the clobetasol isn't putting a dent in it and the first biopsy does not correlate with the clinical picture, biopsy again and make sure it's a 4mm punch of the most infiltrated area with MFPP in the differential so the microscope jockey can be on the lookout. Treatment is similar to classic MF except for a preference for site-targeted modalities. This case was successfully treated with radiation, for example. Extracutaneous dissemination is rare, but tumorous lesions should prompt a PET scan. While odds are that you won't encounter MFPP, this case serves as a valuable reminder that unexpected responses to therapy should cause you to reevaluate your diagnosis. Should you be worried about the liver of that long-term methotrexate patient you inherited? According to an editorial published in the May 2023 issue of the Journal of Hepatology, methotrexate hepatotoxicity is typically acute, dose-dependent, and uncommon at doses typically prescribed by dermatology clinicians. In fact, there is growing evidence that hepatic fibrosis has more to do with comorbidities than chronic methotrexate exposure. A prospective observational study of 1,314 patients with psoriatic arthritis published in the September 2025 issue of Rheumatology found that less than 12% developed liver fibrosis at follow-up, median 5.6 years, and it was not independently associated with cumulative methotrexate dose, but with higher BMI, odds ratio 1.03, and especially diabetes, odds ratio 5.03. Metabolic dysfunction-associated steatotic liver disease, or MASLD, formerly known as NAFLD, i.e. non-alcoholic fatty liver disease, often accompanies obesity and diabetes, and has an incidence rate of about 30% among psoriatic arthritis patients. Of course, excessive alcohol consumption has also been reported to increase the risk. So what do you do if that patient you inherited is an obese diabetic drinker and does not want to change therapy because methotrexate has always worked for him? Fortunately, liver biopsies fell out of favor in the early 2010s, but they used to be done after patients had taken 1.5 grams of total methotrexate. And at 20 milligrams weekly, it takes less than a year and a half to reach that. These days, you don't even need to know what their cumulative dose is, just a current CBC and LFTs, which you're ordering anyway, to calculate the AST to platelet ratio index, or APRI, and or the fibrosis 4 index, or FIB4, which incorporates ALT and patient age for increased specificity. Both formulas are commonly used to assess fibrosis in patients with liver disease and are easy to calculate. Just plug the numbers into MD-Calc. Per the 2023 American Academy of Dermatology/National Psoriasis Foundation guidelines, this calculation should be done every 3 months for the first year, then annually thereafter. If the APRI is less than 0.5 or the FIB4 is less than 1.3, the patient has a low likelihood of significant fibrosis. Caution, results may be skewed if the patient has thrombocytopenia or elevated liver enzymes for other reasons. If the numbers cross those thresholds, refer to hepatology for fibroscan elastography. Fortunately, fibrosis is reversible, but how do you prevent it? Well, you already are, as folate supplementation reduces the incidence of transaminitis, and comorbid risk factor mitigation, of course. Thanks to the authors for retriaging the risks in long-term methotrexate use. They even suggested that methotrexate may be modestly hepatoprotective, given its role in reducing systemic inflammation and improving metabolic markers, and they note a previously observed protective effect against the development of chronic kidney disease in psoriatic arthritis patients. Since we now have red light caps for hair loss, why not headphones for rosacea? Let's say you have a beet red rosacea patient who stays rosy no matter what you throw at them. Oxymetazoline and low-dose doxycycline help, but not enough to celebrate the win, so you get brave and prescribe paroxetine or maybe even carvedilol, but they don't tolerate it, and botulinum toxin is cost prohibitive. So now what? How about transcutaneous auricular vagus nerve stimulation via a headphone-like device that patients wear for 30 minutes a day while cooking dinner or walking the dog? Researchers in China conducted a single-center, randomized, double-blind, sham-controlled device clinical trial of 72 patients with erythematotelangiectatic rosacea. The results, published October 8, 2025 in JAMA Dermatology, showed that after only 3 weeks of treatment, transcutaneous auricular vagus nerve stimulation achieved clinically significant improvements in facial erythema and flushing, as well as anxiety, depression, sleep disorders, migraine, and fatigue. Sounds like an old-fashioned cure-all snake oil, but these comorbidities have neuroimmune and autonomic dysfunctional etiologies in common with rosacea. And transcutaneous auricular vagus nerve stimulation works by activating the cholinergic anti-inflammatory pathway to suppress TNF-alpha, IL-1 beta, IL-6, etc., so it's plausible. But as always, more studies are needed. By the way, it works on Th17 and Th2 pathways too, so are psoriasis and atopic dermatitis next? Symptom improvements were sustained through the post-treatment period out to the 24-week follow-up, and no concerning treatment-emergent adverse events were reported. Basically, mild tinnitus, which also occurred in the sham group, and urticaria, which resolved in 1 to 5 days. And it's safe for pregnant patients too. So you've got a red desperado who also happens to be a gadget guy that's eager to get his ears on one of these units. The study dose, which was 30 Hz stimulation pulses with a 200 microsecond pulse width, is only available with research devices not generally available to consumers. But patients can get close with devices available online. The NeuroSim/Parasim device might be the best dose match at 20 Hz with 200 microsecond pulse width, but distribution in the US is restricted. For US consumers, Pulsetto produces bursts at about 30 Hz, but does not publish its pulse width. So transcutaneous auricular vagus nerve stimulation might not be quite ready for prime time, but as soon as Beats releases an FDA-approved model, Derm Drop will let you know. And that wraps up episode 18. Derm Drop is written and hosted by me, David Sider, with distribution and administrative support by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Sider, spelled SEITER. Questions and comments can be sent to us at dermdrop@gmail.com. And if you had a good time and learned something useful, give us some love with a thumbs up, 5 stars, a comment, or review, and be sure to tell your colleagues. Thanks for listening, and tune in again in 2 weeks for more dermatology quick picks in the next episode of Derm Drop.